As well. Hi, everyone. Thank you so much to those of you who are joining live and to those of you who will watch later. So we're going to have another ECG session, and hopefully you guys will learn something. Now, the ECG may seem complicated, but there's actually just one fundamental thing that I want to get out of it for you guys so that you'll understand one particular diagnosis. But as I put on the group, the particular ECG that we've got today actually has two different pathologies that are going on. One of the pathologies is benign, and one is actually quite dangerous. So I'm more interested in the dangerous one, but also to teach you about the sort of benign one. It's one of those that is often brought up in medical rounds, or if you're doing cardiology or ICU rounds. And it's something that sometimes the seniors just bring out just to make the juniors feel a little bit silly. And if you do know about it, it's quite an interesting bit of info and a bit of interesting it's a good diagnosis to have in your arsenal. But for those of us who are working in the emergency department, it often doesn't come into play that often. That's the benign one. But the pathological one is one that we do worry about. So let's have a look at this. So we have a 54-year-old man who presents with lightheadedness during walking. This is the type of thing that you would, for example, get in an emergency department, and you may not even consider it that serious. You may even just check the patient's vitals, maybe just put them on a monitor, because there's a lot of things that could cause this, and it may be something serious, it may not be something serious. It's just lightheadedness at the end of the day. However, when you put the patient on your monitors, that's when you start to notice a problem in that your patient is a bit bradycardic. So if you had to look at 1, 2, 3, 4, 5, 6, you're coming down into the mid 50s, as far as your heart rate goes. So you say, okay, I've got a low heart rate, I've got a bradycardia. What type of a bradycardia do I have, and is this a worrying sign? So bradycardia will often present in these ways. Of course, if it's a severe brady and it's a severe pathological brady, your patient will present with one of the cardinal signs of altered mental status, chest pain, signs of acute failure, things like that. However, this particular patient just presents with lightheadedness. So now you've got your ECG in front of you, and the first thing you may notice is that something seems odd, but you need to analyze it properly to be able to determine what's odd, besides just a few tall R waves and a few deep S waves. What is really going on? And as we go into it, we'll start to see that there's actually quite a bit that's going on. So the first thing let's have a look at the sorry about that. There's always spam calls coming in. So the first thing that we notice is that we've got an upward-facing lead 1 and an upward-facing lead AVF, which, if you've been following, you should know by now, indicates a normal axis. So at least we know electricity is going in the right direction as far as this heart goes. Now and we've already discussed the rate. Let's first look and see if we can see any ischemia in any particular areas. So if we look at the inferior, if we look at the inferior zone, so that's leads 2, 3 here, and lead AVF, you could argue there's maybe a slight ST elevation, especially in lead 3. But even if it is there, it's just about half a block or so. So it may be significant, it may not be significant. Then if we look at AVR, we don't see any sort of ST elevation or depression or anything like that. If we come to V1, the first thing we notice is just a bit of a bundle branch block. Now, this is almost a complete bundle branch block because it is starting to get a bit wide, but it's sort of like on the border between the two. So you would say approximately about 4 blocks should be, a complete. This falls just below that, so it's an incomplete right bundle branch block. When we come to V2, you start to notice this deep. Now remember, it's an RS complex, and this is not an ST elevation. This is a high takeoff. If we come to lead V3, we see again another tall R wave, which we can see in lead V4, in lead V5 as well. although not in the other leads. You could argue maybe this patient has a bit of left ventricular hypertrophy, but it depends. Is the patient hypertensive? Is there a problem with the placement of the leads? From this, you wouldn't say for sure there's definitely left ventricular hypertrophy, but he's maybe getting in that direction. Here again, we see there's no real ST elevations or ST depressions, so we can't really say for sure that this might be ischemic in nature. Now, let's get to the interesting part. Let's have a look at the rhythm. Now, the unfortunate part is they don't give us a full rhythm strip. So we're going to try and work at it the best that we can. So the first thing we're going to do is have a look at our P waves. So the one thing you notice about the P waves that are over here is that, number one, they're quite peaked when you do get them. All right. So especially when you get these peak type of P waves, especially from what you can see here on the inferior and the right side, it often indicates atrial enlargement. Now, it's good if you can differentiate between right and left atrial enlargement. In this particular case, it's right atrial enlargement because the first half is more dealing with the right atrium. So you can see it's a very high takeoff, and then it sort of normalizes again after that. And there's a few other reasons, but we won't get into those right now. But what's interesting is that if we look at the PR intervals, number one, we notice that there doesn't seem to be much of a relationship between our P waves and our QRS complexes. Now, our QRS complexes also borderline wide, but the main thing is that there's not much of a relationship. In fact, here you can see this looks like maybe a P wave hidden in there. There's a P wave there, a P wave there, a P wave there. You see another P wave hidden inside over here. These could also be P waves sometimes when we see these, what look like, what I've shown you guys before, Osborne waves, which are in normally seen in hypothermia. Here you can see what looks like another P wave. So what we've got here, and this should make you start thinking already. We've got now a ventricle that is functional, and that even though these QRS complexes are a little bit wide, they're not completely wide. So there must be something that's happening from the atrium to the ventricle. And at the same time, there doesn't seem to be much association between what's happening with these atria and what's happening with these ventricles as well. So it's quite an interesting one, in that why is that happening? Why do we have our atria functioning in one way and our ventricles functioning in almost a completely different way? So let's have a look at our atria. Let's try and see. So we've got one there, and then if we go 1, 2, 3, 4, let's say 3.5 blocks, and if we go maybe let's say 1, 2, and we can see even the distribution of them of these particular P waves is not consistent as well, So you've got P waves that are maybe hidden, but they're also not regular, and they've got no real connection to the QRS complexes per se. Or you could say that there's elongated PR intervals at some point. At some point, there's no QRS related to every P. And anybody is welcome at any stage to stop me and to ask questions if I'm talking too fast or if you don't get what I'm trying to get at. So if you are working in an emergency department and you see that the atria and the ventricles are not really talking to one another. So your atria are doing one thing on the one hand, and your ventricles are doing something else on the other hand. So in this case, the ventricles are quite slow. They're only going at about 50 to 60 beats per minute. And we can see our atria, although a little bit faster at times, can also be quite slow at times. So what's happening is that you've got an atrium that's functioning sort of on its own and a ventricle that's functioning on its own as well. Although I've taught you guys in the past that generally when your QRS complexes are wide, that's how you know that the ventricle is functioning completely on its own. This is one of those odd cases where the ventricle is actually getting some sort of input from the atrium, but the majority of the time it's not. Now, if you are sitting in an emergency department at 3 in the morning and you're thinking back to all the lectures that you've watched, this is a horrible thing to see because you're going to be like, okay, I've become even more confused than what I was before I knew about ECGs. Because a lot of the things that I've been taught about ECGs kind of don't really apply to this one. And we'll get into why in a little while. But the question is that are you worried about this patient or not? And my answer to that would be yes, I would be very worried about this patient because you've got ventricles, like I say, that are functioning on their own and atria that are functioning on their own. And regardless of how the QRS complex looks, this is an indication for a or the sign of a complete heart block or a third degree heart block, which is one of the things that we've got going on over here. And a third degree heart block is, of course, a highly dangerous situation to find for a patient to find themselves in because they're on the verge of complete, severe bradycardia, complete cardiac arrest. There's a lot of things that can occur after that. So this patient is in a lot of danger. So let's get into what's actually happening in this ECG. Let's just look at that. So we've got a sinus rhythm with AV dissociation, atrioventricular dissociation, and third degree AV block. We've also got an AV junctional rhythm, but that's the reason why we're actually seeing some um, narrowness of the QRS complex. We've got a rate that's very low of 54 and a biatrial enlargement. So this is quite a complex ECG. Now, the thing is the AV junctional rhythm. Let's get into that. The AV junctional rhythm just means that at times, like I said, the QRS complex is narrow majority of the time, even though for a third degree heart block, your QRS complexes should be wide. The reason for that being that your ventricle is not getting any sort of signal from your atria, so it should be producing its own signal, so it should have a wide complex. However, in this case, because there's some pacemaker cells that are left over, they're the ones that are actually occasionally producing this ventricular rate. They're helping the ventricle to move along. And then AV dissociation and third degree AV block are often used interchangeably. And we're going to get into the nitty-gritty of why they're not the same. But again, if you're in an emergency department, you would start treating this patient as a third degree block. The biatrial enlargement has to do, like I say, with those peak T waves. Sorry about that. With those peaked P waves, sorry, that we were talking about. Although in this case, it does look a little bit more right than left, but in any case, they say it's biatrial. Now, before you get worried and you start thinking to yourself, oh my God, you know what, this is a bit too much. I'm going to switch off the video right now. I'm going to get off the Zoom call because this seems a bit too intense. My whole point of doing this ECG was to show you that even though there's so many pathologies going on over here, the main one that you need to worry about, especially in an emergency department, is the third degree AV block. We're going to talk about AV dissociation in a few minutes, and I'll talk about junctional rhythms in an upcoming one. But the reason why I say this is because the third degree AV block is the one that could kill your patient. And if you can recognize that the atria and the ventricles are not functioning together, even though this doesn't fit exactly what you've been taught about third degree heart block, but there's a possibility that it may be there. And it just goes to show you that sometimes things may just fall outside of what we consider a pathognomic pattern for an ECG, but that doesn't mean that it doesn't exist. Now, even if you weren't able to make the diagnosis of a third degree AV block and AV dissociation, AV junction rhythm, the most important thing that you would need to recognize, again, like I say, atriums, ventricles not functioning together. I'm sitting in an emergency department or even in an outpatient's department or even in a medical ward. I need to understand that there's something going wrong and I need to get somebody to assist me, even if I'm not 100% sure on the diagnosis. But if you can make this diagnosis, that puts you really in the top echelon of, the people who can read ECGs. So don't worry. If you did get that and you did get that from your looking at the ECG when I posted it on the group, I'm exceptionally proud. That is amazing. If you got one of these, I'm still extremely impressed that it shows a good amount of understanding. So what we've got is that we've got our sinus or atrial activities going at about 97 beats per minute. As I said, some of the atrial complexes are not visible. They are hidden within these QRS complexes and T waves, but the atrium and ventricles are independent because of this variable PR intervals and different atrial and ventricular rates. Now we're going to get into again AV dissociation. I don't want to get into all of this because it's quite nitty-gritty, and it's not something that 95% of people working in a hospital setting or even in a private setting would ever need to use. So I'm not going to stress too much about that because this really comes down to amplitudes and things like that, and it's mainly cardiologists and physicians who will deal with that. So this is just something that if you want to impress your consultants, if you are doing a medical rotation, or it's a good, I would suggest taking a screenshot of this because it just tells you the difference between AV dissociation and third degree heart block. Like I say, they're often used interchangeably, but they're actually two very distinct entities. So AV dissociation shows independent atrial and ventricular rhythms, and they may occur because the ventricle is functioning faster than the atrium itself, or there's some interference that's happening between the atrium and the ventricle. Whereas with third degree heart block, there's a conduction block between the atrium and the ventricles. So in other words, something's caused the conduction system to break down. In this case, it's a difference between the rate. Now, the easiest way to understand the difference is that AV dissociation, there's no conduction block. The conduction system is still working. It's just that the rate at which it's working, the SA node, and the rate of the AV node differ. In third degree heart block, there's no association between your SA node and your AV node. I hope that makes sense. But again, it's one of those things that you can use to impress your consultants and your seniors. And if you can pick it out in an ECG or you can explain the difference, that's extremely good. But the main thing is AV dissociation, the conduction pathway is intact. Third degree heart block, there's no connection. The conduction system has been completely disrupted. Okay. So some ECG findings, if you want to get into it a bit more, the P waves and QRS complexes are present, but they're not associated to one another. And it's the rates of the atrium and the ventricles that differ. And then here you'll see the P and QRS complexes are completely independent with generally a bradycardia, which is what we see over there. So they can be similar in AV dissociation, the rates. However, in third degree heart block, you normally get a bradycardia. Now, the main thing is that AV dissociation is benign. Third degree heart block is pathological with a high risk for poor perfusion. So it's a very dangerous diagnosis. AV dissociation is a dangerous diagnosis to make in an emergency setting. To be safe, you rather call it a third degree heart block, treat the patient as such, and then let somebody else who is maybe more specialized in the heart actually decide on the final diagnosis. So how do you manage them? Well, for AV dissociation, there's not really much. It just depends if a cause is found. And generally for third degree heart block, these are patients who require pacemaking. They may need ICU admission and things like that. So your patient comes in with an ECG similar to that. You now have been listening to teaching on heart blocks and AV dissociation, but you've now given yourself so much of information that you are not sure of the diagnosis. You have to treat this as a third degree heart block. That's the best way for you to stay safe in an emergency department. So you go through your normals, your A, B, C, D, E's, you make sure that your vitals are okay. If your patient is stable or unstable, it will guide your treatment. So your patient needs to be on continuous cardiac monitoring. And of course, you obtain a 12-lead ECG, and a rhythm strip would, of course, be very valuable. Now, on most of the machines, you have what they call a manual mode, and most people actually don't use it, but it's an extremely valuable thing because your manual mode actually is a rhythm strip based on a good view of your leads. So, if you can let that run for a minute or two, hopefully your hospital is able to afford the paper. And if not, we can just run it for maybe half a minute or so. But just to give you an idea of what's going on. And it helps if the patient is going to go to ICU or to be referred to a cardiologist. Of course, we would initiate IV access, we would give fluids if necessary, unless the patient is in failure. Now, you can sometimes consider symptomatic treatment. So, for example, if our patient here was lightheaded, but let's say hypotensive as well, because it's got a narrow complex bradycardia, you can give atropine. But I'll be honest, majority of the time for patients who present with third degree heart blocks, atropine is not really that effective. You'd be much better off giving the bradycardial adrenaline dosages, which is 1 amp in 200 mils of fluid, running between 5 to 10 mils per hour. So it's about a quarter of your normal strength adrenaline that's used for, inotropic support. So you just use 1 amp instead of 4. But the most important thing is to try and get senior advice as quickly as possible, especially if you're a junior and especially if the patient is hemodynamically unstable. Now, the one good thing to know is that if your patient has AV dissociation, it's very unlikely that they'll be unstable. So if a patient is unstable, there's a very good chance that this is in fact a third degree heart block. Your patient is going to be either going to need transcutaneous pacing or transvenous pacing if they don't respond to any of the medical treatment, which we've covered in previous lectures and in previous sessions. So if you want to go back and have a look at that, that's always a good thing to do. Transcutaneous pacing, like I say, I've covered before, and it's a good thing for anybody and everybody to know about. And you should, be familiar with that if you're working in an emergency department, how to set up your pads, how to set up your pacing mode, how to set up your voltage and your rate, and then how to manage that from there. But it's too much to discuss in our short session today. Keep your patient calm, explain to your patient what is going on, because as they say, anxiety is actually worse, especially if there's an underlying ischemic cause. You're going to increase your oxygen demand on your cardiac tissue, and that's going to make it even worse for the patient going forward. Try and avoid anything that will make it worse, such as beta blockers, calcium channel blockers, which are unlikely to be used in the situation, but you never know. You may be overseeing a junior and you might see them suddenly writing up a beta blocker or calcium channel blocker for some reason because they saw maybe this query sign of ischemia and they know that you give beta blockers. So this is just something to remember. And especially in these cases, documentation is always important because there's a good chance that the patient will go through to an ICU. Okay. Oh, sorry, but that's actually the end of it. So I just want to know if there's that's just a joke to finish off. Food does unfortunately fill the void in your heart eventually. Unfortunately, it's just not a pleasant sensation when it does. So I wouldn't advise anybody to go that route. So I'm not sure if there's any questions from those who have joined live. But the one thing that I can say is that looking at the ECG, if you working independently or in a unit or whatever it may be, at least decided that, listen, this looks dangerous. This looks like I need to do more, or I'm not really sure what's going on and I need to take this further. I need to ask somebody for advice. I need to ask somebody for an opinion. You've actually won 90% of the battle because the person who you speak to, even if they don't know, may ask somebody more senior, or that person will be able to advise you and say, listen, there is something going on and this is what we need to do. Now, it does take a few minutes to analyze these types of ECGs. And if you were to just give this a quick glance, it would actually look relatively okay. It actually doesn't look that bad. It's only once you start looking at your P waves and your QRS complexes and you start to notice these things that you start to realize, listen, there is a problem. There is something going on. So, I hope everybody gets an idea of how important it is to really have a look at your rhythm strip, because everything is not ischemia. A lot of people feel that it's either ischemia or it's nothing. The truth is that rate and rhythm disturbances actually account for the majority of problems and are very often the sequelae of or the consequences of ischemia. So it's very important that you know how to read your rhythm strip. So remember your rhythm strip, you look at your P wave itself, you look at your PR interval, you check if your QRS complexes are narrow or wide, you check if a QRS follows every P. In other words, does the ventricle contract after the atrium, which of course now in this case you would realize that it doesn't. And of course are the bundles regular, which in this case, even though the QRS complexes are regular, you would notice that the atrial component is not regular. You would notice there's a PR problem. You would notice the P waves themselves are abnormal. So there's quite a bit that you can pick out from the rhythm strip. The only part that would confuse a person would be these narrow QRS complexes. But then, like I say, that's why I put it in here so that you could understand that even though something may not fit into what you would consider absolutely diagnostic of a particular problem, there may be reasons why it doesn't fit exactly into that. And if you suspect something, make sure that you get help. Make sure that you ask somebody, so that you can get help on that. And third degree heart block will often be admitted to an ICU or a high K cardiac unit, and they'll be managed from there. So if everybody is happy and if everybody is okay with the explanation, then we're going to call it an end for today. And I'd like to thank those who joined live, and I'd like to thank those of you who are watching later on. Thank you.